Well, thank you very much for inviting me. I see a few familiar faces in the audience, but actually one of the most familiar faces is Henry's, because I've known Henry in a weird kind of way for about 15 years. In fact, Henry's probably responsible for piquing my interest in narcolepsy in the first place. My colleague Matthew Walker, who some of you may know, has been punting Henry's video of his cataplexy around every clinical meeting that he's ever talked about narcolepsy in. And so I first saw Henry's video probably about 15 years ago. Would that be about right? Yeah. And so Henry's video was the first case of cataplexy that I ever saw. And in a way, you've led me here on two separate occasions. So I'm going to talk about, because I think it's really important for us as a medical community, for you as a patient community, to understand where some of the blocks are in terms of achieving the diagnosis of narcolepsy. And some of that is very much at our end, even at the level, have we got a bit of reverb? Sorry. Shall I move away from the speaker? I'm going to move this side. So, is that better? So, I think it's really important to understand where those blocks to the diagnosis are, because one of the biggest issues that I see on a regular basis is people who have narcolepsy who have gone for a number of years undiagnosed. And in hindsight, everybody says, well, how could we have missed a diagnosis? But actually, people are taking several years sometimes to get to the point where they can actually initiate treatment. Now, it needs to be stressed that treatment is not always terribly successful. For the most part, it improves people's quality of life tremendously, but really getting to that point of treatment is what is going to make the biggest difference to quality of life. Actually getting to that diagnosis, understanding why you are in the position that you're in, and that it's not due to being lazy or being depressed or the countless other diagnoses that I've seen attributed to narcolepsy, that is a huge part in the patient journey. So, as I've already said, it is one of the biggest sources of frustration for patients and families. The sodium oxybate story is another cause of frustration, and I'm very happy to talk about that at the end. I'm just going to point your attention to the pointer doesn't work. So there was a paper done in 2004, which was actually done with the precursor of the Narcolepsy UK Society. The narcolepsy patient organisation at that time, which sent out a survey to hundreds of people with narcolepsy. And they reported that the median time to diagnosis at that time was 10.5 years, which is really quite astounding. Now, even if you have cataplexy, or at least if you had cataplexy at that time, although it wasn't 10.5 years, it was a bit shorter, it was still 5.5 years, which actually beggars belief, because cataplexy should be something that is very readily identified, that clinicians should know about, and should really flag the fact that what you're dealing with is not depression, is not sleep restriction, that this is something neurological. What we saw from that paper is actually we have got a little bit better as a medical community in terms of diagnosing narcolepsy, so there's a clear reduction in time to diagnosis over the last few decades. And if you developed your symptoms after 1980, the average time to diagnosis was 3.5 years, which is still a very long time. 3.5 years not to know that the reason why you've got the symptoms is because of a neurological disorder. And narcolepsy is about as pure a neurological disorder as you can possibly get. You have a condition that is caused by damage to 70,000 or less neurons in the brain, which in neurological terms is a tiny number, and that really is largely responsible for every single symptom that people with narcolepsy have. So it really is a very pure neurological diagnosis. So why should it still take that long? I suspect probably if we were to do the same survey now, it would be a little bit less, but probably not that much less. And I would perhaps argue that this study needs to be done again to see where we're at, because that would inform the organisation and the management of narcolepsy services in the UK. So I'm new to Twitter. I'm a very late comer to Twitter. And in preparation for this talk, I tweeted to my 3 Twitter followers. Luckily, all 3 responded. What was the major obstacle to your diagnosis? And you can see, and this is really representative of many of the discussions that I've had with my patients. So one said, well, being overweight, even though I haven't always been overweight, so then it must be depression. Probably quite a familiar story to some people in this room. On a rare occasion, a doctor thought there was something wrong with me, but they said it was depression, but I knew it wasn't. I've already had one discussion with somebody today who said that the GP that they were seeing refused to accept that it was anything other than depression. And I wasn't diagnosed for 25 years. People just said I was lazy. So, really quite depressing, small sample size, I'll accept, but really quite a depressing response. So I thought it would be helpful just to talk through the stages of the diagnostic pathway, the way that people get to the final diagnosis of narcolepsy and subsequently initiate treatment. So obviously there is the step of the recognition of symptoms by the person who's suffering from narcolepsy, that this is not part of the normal spectrum of sleepiness, that the family accepts that there is something wrong. And I've certainly seen plenty of people who said, well, my child just started being very sleepy. I thought they were being bullied at school, and it took me a while to figure out that actually there was something really genuinely wrong. Although in my experience, actually most parents of children with narcolepsy are very, very sensitive to the fact that something is wrong. There is the consideration of the diagnosis by the GP, because as we know, the GPs are the gatekeepers to the NHS, and in order to get that referral, you have to convince your GP that there is something wrong. There is the process of getting to a sleep clinic, and even once you're in a sleep clinic, you may spend quite some time before the sleep clinic comes to the diagnosis of narcolepsy, and I'm going to discuss some of the issues surrounding that. And then there is the ability to access appropriate diagnostic testing, and very importantly from my perspective, and this is a subject of some of the research that my group has been doing at Guy's Hospital, the interpretation of those diagnostic tests, which are a major issue, not just in the UK, but I've seen numbers of patients from the States in whom the interpretation of that diagnostic testing has not been undertaken correctly. So I'm going to start off with recognition of symptoms by the sufferer or their family. I think it's still true, even despite, your activity in the media and lately my activity in the media, which I'm not going to talk about too much, but most members of the public have really never heard of narcolepsy. And if they have heard of narcolepsy, they kind of see it as this joke thing of people falling asleep, whilst on the football pitch and various other things. So actually, the knowledge of this as a diagnostic entity is very limited in. I can see one of my tweeters, one of my 3 tweet followers out there. I think that's a major issue. So if you are a standard, normal family, you're like everybody else in the population. You, in all likelihood, have never really heard of narcolepsy. And when your family member starts feeling sleepy, how are you going to know that there is this entity called narcolepsy? And I think and that's much more, even more the case for cataplexy. So people don't know what cataplexy is. They've never heard of cataplexy. Even my friends who I talk about, who are non-medical, who I talk about my work, and I talk about cataplexy, they're amazed. These are, educated people, some of whom have done, degrees in the medical sciences at university, who've never heard of this condition. So I think people can't be blamed for not knowing about this condition. And I think part of your job and my job is to disseminate that information more widely in the population. I'll come back to that. One of the other issues is that because the symptoms very often come on very gradually, there's not this immediate, sudden, catastrophic sleepiness that people experience. Occasionally that does happen. Occasionally people do develop devastating onset of cataplexy, but these are rare it is. And so this gradual onset of these symptoms can make recognition of this as being a problem much more difficult. And because the onset, and we all know that actually one of the peaks of onset is around the age of 15 or 16, that's the time when teenagers are often playing on their mobile phones, are often going to bed a little bit later, they're having difficulty getting up in the morning to sleep, and so poor sleep is often simply blamed as underlying this condition. So what about once you've managed to recognise that something is wrong? You get to your GP, the GP says, well, I don't know, I think you're either lazy, or you're not sleeping enough, or you're a bit depressed, or you're a bit overweight and you need to lose some weight. And I think that part of the reason is that GPs are inundated with people who say, I'm tired all the time. But it's really important to discriminate tiredness from fatigue, from sleepiness. They are not the same thing. You know, there are countless causes for fatigue, hormonal issues, depression, anemia. But actually, once you've recognised that the person sitting in front of you is not just complaining of fatigue, and I would define fatigue as that feeling of exhaustion that is caused by mental or physical exertion. Okay? It's very different from what people with narcolepsy, or indeed people with other sleep disorders, also report. They report the fact that actually when given the opportunity to sleep, or even when not given the opportunity to sleep, they will fall asleep. And actually most people with fatigue, they will say, I need to lie down, I need to rest. But if you say, well, but are you actually falling asleep? They'll say, no, I'm just resting there with my eyes closed. It's a very, very different picture from people with sleep disorders. And I think one of the major issues is that GPs have a very poor knowledge of sleep disorders. It's improving, but it's still very poor. And that really is not their fault. It's the fault of the medical school curriculum, because even when I was at medical school, I think I probably had about 15 minutes of any sort of education about sleep disorders. So in a 6-year course, and then subsequently in my 10 years of neurology training, I probably had, as part of the formal curriculum, I probably had an additional hour. Okay, that's changing a little bit now. It's changing due to the work of some of the neurologists who are very actively involved in the sleep world, and there are changes now within the medical school curriculum. People are understanding how important sleep is to our general health, and are starting to understand some of the pathologies that influence sleep. So I think that is slowly changing. So even once sleepiness has been identified as being the issue, the GP is likely to make some assumptions about what the cause is. So that, you know, is this poor sleep, is this depression? And I think that really comes out of some of the confounders of sleepiness, but it also results from that poor knowledge that they have as a baseline. And because of the myriad of symptoms that people with narcolepsy get, even if they do successfully achieve a referral, that referral doesn't always go to the right place. So, you know, if people have cataplexy, they will end up in a neurology clinic. And I've already talked a little bit about the limited knowledge that many neurologists have about narcolepsy and about sleep disorders. So they'll often be worked up for possible epilepsy. Actually, cataplexy shouldn't be confused for epilepsy. There are very, very few cases in which a cataplexy-like picture can occur in epilepsy, but this is usually in the context of a highly abnormal brain, so really should be picked up. It's often mistaken, in my experience, for something called NEAD, non-epileptic attack disorder. So these are psychogenic, psychologically driven attacks, and I've seen countless people who've been told that their cataplectic events are because they're a little bit mad, and I've seen it put in those terms. It's quite depressing, really. Or a condition called drop attacks that result from abnormalities in a part of the brain called the brainstem. And I've seen lots of people who have come my way through cardiology because they present with drop attacks or major cataplectic events, and they're mistaken for some sort of cardiac rhythm abnormality or some other cardiac disorder. And I've seen numbers of patients who have been referred through to psychiatry because of sleep paralysis, usually associated with hypnagogic hallucinations. And if you're lucky, you'll see a cardiologist, you'll see a neurologist, you'll see a psychiatrist who knows a little bit about narcolepsy. But I think there are probably countless people sitting in these clinics at the moment who have narcolepsy that is unrecognised. Feel free to chip in with questions or comments, by the way. Don't let me talk unhindered. So then there's the next step of getting to the sleep clinic. Depending on where you are geographically, it's a bit of a postcode lottery, because in the UK, most sleep clinics have been predominantly set up by respiratory physicians who are interested in snoring and obstructive sleep apnea. So, and those clinicians who you see in a sleep clinic are likely to be particularly interested in sleep apnea. So really what they will be looking at is, does this patient have sleep apnea? If they do, I'm going to slap on a machine called CPAP, which some of you may be aware of, and this is one of the comorbidities that's associated particularly with type 1 narcolepsy, largely through the mechanism of weight gain. We see a number of people who have sleep apnea in addition to their narcolepsy, but when the patient doesn't respond to CPAP, or when they respond a little bit to CPAP because they do have sleep apnea, they can say, well, that's the diagnosis, we're going to send you away with a machine and we'll see you again in 10 years' time when you complain of new symptoms. And because many of these services are set up purely to explore the possibility of sleep apnea, they have very limited diagnostic testing. So as anybody who has got narcolepsy in this room will know, the standard diagnostic test is the polysomnogram, so that overnight admission, followed by the MSLT, the NAP test that you undergo the following day, and actually most sleep centres do not have that facility. So once these centres have excluded sleep apnea, or hopefully excluded sleep apnea, and they think about the possibility of narcolepsy, then they will need to refer you to a tertiary sleep clinic that has those facilities. And so hopefully, if you're still sleepy on CPAP, you will end up at one of these tertiary facilities. And even when you're in the sleep clinic, there is a significant overlap between some of the features of narcolepsy and other disorders. So the disorders that can look rather similar to some aspects of narcolepsy include this entity called BIISS, or behaviourally insufficient sleep syndrome, basically chronic sleep restriction, sleep apnea, which I've already talked about, circadian rhythm disorders. So these are individuals whose internal body clock is not on the same time, on the same clock as the outside world. So for example, people who want to go to sleep very, very late and wake up very late, and that can result in significant sleep deprivation, or actually more rarely, people who want to go to bed at 6 p.m. and want to wake up at 2 or 3 a.m. So this can have a major impact in terms of levels of sleepiness during the day if you are sleep restricted. So it's not so straightforward as just identifying that somebody's a bit sleepy and they haven't got sleep apnea. There are other conditions like periodic limb movement disorder, recurrent kicking at night, a neurological disorder that's associated with a condition called restless leg syndrome. This is seen at increased frequency in people with narcolepsy, so it can often act as a stumbling block to the diagnosis, because you bring somebody in, they've got a lot of sleep apnea, they've got a lot of periodic limb movements, you blame those two things for their sleepiness, and the diagnosis of narcolepsy gets left behind. So all of these need to be excluded before the diagnosis is made. And then this statement, but cataplexy is obvious, really obvious. And indeed it is. But actually generalized cataplexy is seen in probably less than half of people with narcolepsy type 1. And what a lot of people with narcolepsy type 1 have is segmental cataplexy, which is that sort of face slackening that Henry exhibits it in his video, which is, when your face goes a little bit weak, when your tongue goes a little bit weak, so you slur your speech, maybe it just affects the arms, just affects the legs. So people think of, and lots of neurologists that I give talks to are quite amazed to find out that cataplexy does not necessarily result in this dramatic collapse to the floor, because that's what they're taught. Whereas actually the symptoms of cataplexy can be much more subtle than that. And they're sometimes not even recognised by the patients. So I've had people who have sat in clinic with me who I've said, so does anything funny? And I always, whenever I see somebody who I think might have narcolepsy, I always ask a very loose question to start off with. And I say, does anything strange happen to your body when you experience very strong emotion like laughter, your friends tell a joke? And often people say, well, no, not really. And then I ask them more specific questions and I say, well, have your friends ever said that you look a bit strange when you tell a joke? And, there are lots and lots of people who say, well, actually, it's funny you say that, but my mates take the piss out of me, excuse my language, because that's what they say to me in clinic, because I look a bit strange when I tell a joke. But they haven't really recognised that as being pathological. They think that that's part of that's just how they're made. Does that sound familiar to some people in the room? Yeah, I'm seeing a few nods. So it's very easy to understand why cataplexy does not always lead to the diagnosis very quickly. And this is a study, it's not projecting very well, apologies. This is a very elegant study that was done by Claudia Bassetti in Switzerland, who looked at people who had clearly defined type 1 narcolepsy. So these are people in whom their spinal fluid has been analysed for hypocretin, and also looked at people with other sleep disorders and looked at normal controls. And what they demonstrated was that actually even 8% of normal controls report symptoms that are similar to cataplexy, because actually to feel a bit weak at the knees when you laugh is a normal phenomenon. It's normal symptomatically, but even when we look at muscle activity using something called EMG, so where we put electrodes on people's muscles, that's a normal phenomenon. Okay, and in people who have other sleep disorders, they often report cataplexy-like events. And for me, this is one of the most difficult areas, is in people who've got very subtle symptoms of cataplexy. Sometimes that internal feeling without the outward manifestation is unraveling what is cataplexy and what is cataplectic-like events. There are some questions that you can ask to try and discriminate. So they found that if people respond to tickling, and that precipitates cataplexy, then that's very sensitive for narcolepsy. I think I would be struck off if I started tickling all my patients in clinic, but it just gives you some of the illustrations about the complexities in trying to define cataplexy. So, and then the next issue, and I feel like I'm providing a very long list of excuses. These are not excuses, these are just the facts as to why people might take a long time to get a diagnosis. Then there is the nature of the PSG and the MSLT, and I'm going to talk about the actual interpretation of that in a little while, but there's a huge issue with lack of facilities. There are issues of methodology. So even and we like to think of ourselves rightly or wrongly, Guy's and St Thomas's, as the premier sleep centre in the UK, but when we had our sleep studies done at St Thomas's, we had Big Ben directly opposite. So on the hour, every hour, people would wake up because our rooms were not very well insulated. So even things like that can influence the results of the test. So if you are not properly set up to undertake these tests in a very formal way, you can get some abnormal results. And then there are these diagnostic criteria for the PSG and the MSLT. A lot of you will be familiar with this, but I thought it's just worth just demonstrating what we look at on the sleep study and the nap test the following day. So these have undergone some revision that have added an additional layer of complexity recently, but actually what we need to demonstrate is that on the overnight sleep study you've slept more than 6 hours, that there's no alternative explanation like leg movements or snoring, and then during the nap test where you are allowed to sleep 4 or 5 times, depending on what you've done in the first 4 naps, we're looking for you to fall asleep within 8 minutes or less across an average. and whether or not you exhibit dreaming sleep in 2 or more of these naps. Now, do you want to know where these came from, these diagnostic criteria? To some extent, they've largely been plucked out of the air. Now, I think that's overstating it a little bit, because there is some evidence behind this in terms of the sensitivity and the specificity. But these are rather arbitrary cut-offs. Yeah, somebody said, well, if we put the cut-offs here, we're going to capture X% of people with narcolepsy, and we're going to have, you know, what we term false positives of less than Y%. But these are not fixed in stone. There's no clear biological reason why these cut-offs have been made. And so there are major limitations in terms of, yeah. Are you asking a question or are you waving at someone? Oh, sorry. Waving at someone. So, you know, it's not like if your mean sleep latency is 7.9 minutes, you've got narcolepsy, and if it's 8.1 minutes, you haven't. But I've seen lots of people who have been told, no, you don't have narcolepsy because your mean sleep latency is 8.2 minutes. And lots of people who have wrongly been told that they have narcolepsy because their mean sleep latency is 7.9 minutes. Really rather bizarre if you think about it. Because the MSLT, the mean sleep latency test, is it's a biological test. You're basically getting somebody to come in and sleep, and they're in a strange environment, and depending on how much sleep they've had the previous night, depending on how relaxed they feel, depending on whether or not they've been told by their partner that they've got a huge tax bill that morning, or whether or not they've been told that they have to go and meet their child's teacher the following day because they've been naughty at school, it's going to be influenced by a range of conditions, okay? You know, we know that sleep is a function of biology, but it's a function of behavior, it's a function of psychological state, it's a function of environmental factors. And so we're using this test in a kind of highly scientific way to make this diagnosis without really making any allowances for the fact that actually, you know, it may be a bad day, you may be a bit more sleepy that day, you may be a bit less sleepy. So actually, when we look at this test in detail, that even when you use very stringent values in terms of how sleepy you are, so if your mean sleep latency is less than 5 minutes, about 30% of people who meet more stringent criteria don't have narcolepsy. And if you look at a general population, as Mignot did in 2000, 6% of men of working age and about 1% of women had an MSLT that appears to be diagnostic for narcolepsy. So either this test is rubbish, or we've got a lot more people with narcolepsy around than we think we do. And I have very strong feelings of which of those is correct. So this is for another talk that I gave at the BSS a couple of years ago. I did a bit of a back of a envelope calculation just to see how useful it is, the MSLT. So assuming that the MSLT captures is sensitive at about 80%, and knowing what we know about how good a test it is in terms of showing people who are sleep deprived. So 15% of people who are chronically sleep deprived will have a test that is positive for narcolepsy. It's quite a lot. And given what we know about the frequency of sleep deprivation in our society, and what we know about the prevalence of narcolepsy in our society, if you take a person in sleep clinic and you don't ask them anything, and you just push them through an MSLT clinic, an MSLT, and it comes back positive, you stand about a 37 times greater likelihood of misdiagnosing somebody with chronic sleep deprivation as having narcolepsy, okay? Which is really pretty poor. And I would argue that in some sleep clinics, particularly when you've been pushed through one of these tests by somebody who's not a sleep specialist, the results of that test need to be interpreted with a huge pinch of salt, because you need to be asking the right questions before you undergo this test, before you order this test. So I think what I'm trying to illustrate is the complexities in achieving a diagnosis, and even knowing all this, it can sometimes be incredibly difficult. Yeah.
But surely you wouldn't even be put forward for the test unless it was suspected that you had narcolepsy or another
Yes, but that's absolutely right. But it's where that level of suspicion is. So somebody comes into a neurology clinic and they say, I'm sleepy and I'm falling asleep a lot. Some neurologists will just say, well, let's get you in for an MSLT without actually asking a bit more about what's going on. And that's the issue, okay? So by the time you come to a specialist sleep clinic, hopefully they will have asked the right question. But I think it just illustrates some of the complexities in terms of dealing with the results of the MSLT. That's what I'm trying to get across. It's not that, I'm saying that there are huge numbers of people who've been diagnosed with narcolepsy that don't have narcolepsy. I'm just trying to illustrate some of the issues that we in our clinics have in terms of interpreting that, mindful of the knowledge that there are so many false positives. So, overdiagnosis, does it really matter if you say to somebody, well, you've got narcolepsy when you're sleep deprived? Well, I would argue that, yes, it's got huge implications, because overdiagnosis is as damaging as underdiagnosis. So if you are misdiagnosed as narcolepsy, bearing in mind that narcolepsy, as we understand it, is a lifelong disorder, potentially exposing you to lifelong conditions with, potentially significant implications on your social and your working life, I'm very keen to exclude other possibilities before I come to a diagnosis of narcolepsy. Now, it's made a lot easier if somebody says to you, yes, I've got good going cataplexy, and usually the diagnosis is made. But what I'm perhaps talking about is some of those people who don't have cataplexy, so they have type 2 narcolepsy or narcolepsy without cataplexy. And this really illustrates quite how rubbish the MSLT is, okay? So this is a study that was done out of Atlanta, where they took people who'd undergone 2 MSLTs. And unfortunately this pointer doesn't work, but in the top box, they put a number of people through the first MSLT, and of those people, 15 on the basis of the MSLT were diagnosed with narcolepsy without cataplexy. So these are all individuals without cataplexy. So 15, by the time they'd undergone their second MSLT, on the basis of the results of the MSLT, only 5 out of 15 still met the diagnostic criteria of narcolepsy. So some were reclassified into another condition called idiopathic hypersomnia, and quite a lot of them were deemed normal. And I'm not saying that these patients didn't have narcolepsy without cataplexy. All I'm trying to illustrate is the fact that if they'd have had the results of their second MSLT on their first, they would have been told, well, you don't have narcolepsy. Yeah? Does that make sense? I'm seeing a few puzzled faces. And I think that these plots here on this side show the huge variability between the results between their first MSLT, both in terms of the number of dreaming episodes, the number of episodes of REM sleep they had in their MSLT, and how sleepy they were. So very poor, what we term test-retest reliability. So once again, I think illustrating that this test needs to be interpreted with caution. It's not to say that this test is completely useless. We've published a few papers now on which aspects of the MSLT can be very helpful in terms of really firming up the diagnosis of narcolepsy. So depending on what stage of sleep you go into dreaming from, there are some very strong predictors on the MSLT, and indeed we can make some predictions about how likely you are to respond to medication on the basis of that MSLT. But it, once again, confirms in my mind that actually what's most important is talking to the person sitting in front of you and getting a really good history. So I think I've talked about some of this already. I'm going to skip a little bit on this, but Freudian slip, sorry. But what I'm very keen on in people who don't have cataplexy is to make sure that I'm not missing a readily reversible cause. So if I have some doubts as to the diagnosis, then I will undertake things like asking them to take a sleep diary, sending them home with an actigraphy watch, which some of you may have had on, which is this little sleep tracker. And if there is doubt, I will say, look, please go away, we'll try these approaches to modify your sleep, see whether or not that improves matters. Okay, so I am part of the problem in terms of the delay to diagnosis, But I don't apologise for that, because what I'm trying to do is trying to make sure that if there are any readily reversible causes of your symptoms, for want of any better tests that we have, to make sure that I'm not going to diagnose you with an irreversible condition. Yeah? What about HLA type? Well, some of you will have had this blood test done to look to see what genes you're carrying that influence your immune system, and we know that this is very strongly associated with narcolepsy, with cataplexy. So about 98 to 100% of people with cataplexy will have this particular gene type or genetic variant. But if you don't have cataplexy, it's only about 40 to 60%. And about 20 to 35% of the population also have this. So really, it's largely useless. It's no more helpful than establishing whether or not somebody has cataplexy. Cataplexy is the thing that's going to tell you that. And if you've not got cataplexy, then you've probably got a somewhere 50-50 chance of having this gene. But if you don't have cataplexy, you've got a 20 to 35% chance of having this gene. Not hugely helpful, except really to cast doubt on the diagnosis of narcolepsy type 1, which is very rare, actually, by the way. I don't think there are many people who have thought, oh, actually, you know what, I'm not convinced by this and I need to do some more digging. So the lumbar puncture, has anybody had a lumbar puncture here? Yeah, a few people. So, really a hugely helpful test if it's positive. What I mean by positive is that if you don't have if you have a CSF hypocretin that is low or deficient. But once again, if you've got cataplexy, is it more helpful than having cataplexy? Probably not. Yeah.
Well, I actually presented, like you said, I'd inadvertently treated myself with smoking and fluoxetine, and had these funny attacks when I was laughing, and which got worse when I decided to get healthy and not smoke anymore. And had full-on cataplexic attacks. Generally, potent trigger was laughter. And so I went to see a professor, a neurologist, and he said, right, well, let's start you on fluoxetine again for the cataplexy, and we'll do a lumbar puncture. And so I had my lumbar puncture, and my hypocretin levels were normal.
So you're not the first person that said that to me, and we recently wrote up one of my patients we published a couple of years ago, somebody who, I can't see him here today, I'm not going to embarrass him if I do, who had a normal CSF hypocretin. I was completely convinced by his diagnosis of cataplexy, and he wasn't sleepy, he had totally normal MSLT, and then 2 years later we repeated the lumbar puncture and it was deficient. So I think that's rare, but it illustrates some of the issues surrounding lumbar puncture. If you've got cataplexy, you're likely to have a low CSF hypocretin, except there are a few exceptions to that. But in patients without cataplexy, only 40% will have a low CSF hypocretin, and they're often quite borderline. So it's not really helpful in people with cataplexy. If it's positive in people without cataplexy, then it makes the diagnosis. But if it's normal in people without cataplexy, what does that mean? Does it mean they haven't got narcolepsy? No, it doesn't. So, and what you've got to bear in mind is that it is not, it's not the worst procedure in the world if done properly, but it's an invasive procedure. There's a long waiting time. And I would question whether in the vast majority of cases it's necessary at all, actually. And if it is negative in narcolepsy without cataplexy, it doesn't really tell you anything. So, once again, an additional level of complexity to achieving the diagnosis. So, I think I'm going to stop putting obstacles in the way, and I'm going to talk a little bit about how do we improve matters. So I think you guys are doing a huge amount already. You are increasing public awareness. I direct pretty much all of the people that I diagnose with narcolepsy towards the Narcolepsy UK website, because I think it's a fantastic resource. But I think we and you need to be a bit more proactive about engaging with GPs, because GPs are going to be the first step in the diagnostic pathway. And so I think that's really where we need to focus you need to focus many of your efforts. But our role is pretty much exactly the same. So it's increasing public awareness, it's providing reliable information for potential patients, it's informing GPs, going out and writing about narcolepsy. And I've done a recent article for a GP magazine just to try and increase awareness. It's about giving GPs talks. It's about developing a sleep curriculum. So rather than spending 15 or 30 minutes over the course of a 6-year degree on sleep, saying, look, this is a fundamental part of life. And we can't have a situation whereby we focus on the 100 causes of a rash of your little finger without talking about sleep. And it's about developing a sleep training program. So one of the things that we've done at Guy's and St Thomas's, we've actually managed to get some funding for clinical research fellows. So these are people who are interested in learning more about sleep medicine, and we've had people staying for between a year and 3 years to try and train people properly in the management of sleep disorders. We need to work with clinicians working in sleep, so those people who are working in more respiratory-led centres, about explaining to them what narcolepsy is, what the associated disorders are, making sure that they understand the limitations of diagnostic testing, and making sure that they do not underdiagnose or indeed overdiagnose narcolepsy. And unfortunately, that means that we need to communicate with a wide range of specialists who might encounter people with narcolepsy, so neurologists, psychiatrists, cardiologists, respiratory physicians, and psychologists, who often end up seeing people who their GP has said, well, you're a bit depressed, go and see a psychologist. And I think there has been a shift over the last 2 or 3 years in that there are increasing numbers of medical professionals who are now a bit more interested in sleep. So now, when Henry originally contacted me, he said, can you come and talk about the making of this programme? And I said, no, I don't really want to. I share this trait with a lot of clinicians. I've always historically been very anxious about doing anything to do with the media, because it's, I mean, people always say, oh, well, they'll twist what you say, they'll twist what you do. And I've resisted doing this for many years. Actually, they called me as a result of somebody who I'd worked with before, and I thought long and hard about getting involved in this. And actually talking to them, I thought, well, this is a really, potentially a really good thing to do, because it is probably the most powerful way of communicating with the public that conditions like this exist. And I can't tell you the number of people who've come up to me and said, I had no idea. I had absolutely no idea. I just thought you told people to sleep better and to lay off the caffeine and to improve your sleep hygiene. And I think that that this kind of experience has been invaluable in disseminating information about narcolepsy. And I'm just going to play you a little clip, because I think I can see 2 people in the room who were involved in this, and I'm afraid I've only included one because I didn't want to go on for too long, but I just wanted to play this because actually I think Phil's illustration of
not all the patients at the clinic are here for their nighttime sleep
has been
problems.
Absolutely invaluable in terms of demonstrating to people.
In the weird world
Sorry
of
to embarrass you, Phil.
many of Phil's
It has been
problems
really
happen
invaluable
during the
to
day
communicate
when he's
what
awake.
cataplexy is
I've
and what
got,
the impact
condition
of this
called
condition
narcolepsy.
is.
Gosh, how long have you suffered from that then?
So just over a year. I mean, it's just something that came. I've never had an issue with sleep ever.
Do you think something triggered it?
Yeah, well, they think it's flu that's triggered it, and
Steer clear of the flu then
Yeah,
in future.
that's it.
it's an autoimmune thing. So your body attacks your own brain thinking part of your brain that controls your sleep is part of the virus. And the cells can't be reproduced. So once they're gone, they're gone. So it's it's a bit of a tricky one.
Nasty.
That's terrifying.
Yeah.
About 1 in every 3,000 people suffer from narcolepsy. Like Phil, 70% of them will also have a condition called cataplexy.
There's two sides to it. The narcolepsy bit is I'm chronically tired, and the cataplexy, it can manifest itself in me falling to the floor if I experience a strong emotion like laughing. It's any event that I feel is funny, so it's an emotional connection. The first event that ever happened was trying to put the children to bed. I fell to the floor and wasn't able to get up. The kids were laughing, they thought I was just play acting. And I was just lying there. I could hear them and I could see them, but I was unable to speak or move. It was bizarre and just didn't know what it was. And it turns out it was the cataplexy starting to take hold. It was quite devastating because I was unable to do anything.
So I think Phil then goes on to describe the impact that it's had on his ability to emote, to engage with his family. And I think, and Phil, so many people have come up to me and said, you know, even those people who knew about cataplexy have come up to me and said, God, I had no idea that this is the impact that cataplexy or narcolepsy has. Okay, it's been a really major informative piece, actually, and I think that you and us as healthcare professionals actually need to engage much more with the media, because it's the only way that we actually get the message out there that this is a problem, an important problem, not something to laugh at, not a source of humour, but devastates potentially people's lives. So, and something that we can treat. I'm going to leave it there. Okay, thank you.